Saw Palmetto generates hundreds of millions of dollars in sales annually on the strength of prostate health claims. As a urologist who has followed this research carefully for decades and discusses it with patients regularly, I am going to give you the most balanced, evidence-grounded assessment available, reviewing the actual research rather than the marketing. I'm Dr. James Whitaker, board-certified urologist, and today I am going to do something that I think the men's health supplement space desperately needs. A genuinely honest, evidence-grounded review of one of the most commercially successful supplements marketed for men's prostate health. Saw Palmetto. Not a promotional review designed to sell the product, not a reflexive dismissal from someone who hasn't read the research. A careful, balanced review that tells you exactly what the clinical evidence shows, where the genuine uncertainty lies, and what a thoughtful, evidence-based clinical recommendation looks like. Let me begin with the botanical context. Serenoa repens, commonly known as saw palmetto, is a fan-leafed palm native to the coastal regions of the southeastern United States, particularly Florida and Georgia. The berries of this plant were used medicinally by indigenous populations for centuries, primarily for urinary complaints in older men, before any European contact with the Americas. The first systematic documentation of its use in Western medicine occurred in the late 19th century, and standardized berry extracts began to be studied in European clinical trials in the 1980s and 1990s. Today, standardized lipophilic saw palmetto extract is classified as an approved pharmaceutical agent for benign prostatic hyperplasia in Germany, France, Italy, and other European countries, where it is prescribed by urologists and reimbursed by national health systems. In the United States, by contrast, it is classified as a dietary supplement, which means it is subject to significantly less regulatory oversight, and that the claims made for it are not evaluated by the FDA before marketing. The proposed mechanism of action involves several components. The lipophilic fraction of saw palmetto berries, the fatty acids and phytosterols that are concentrated in the standardized extract, is proposed to inhibit 5-alpha reductase, the enzyme that converts testosterone to dihydrotestosterone. DHT is approximately 5 times more potent than testosterone at stimulating prostate cell growth through androgen receptor activation, and DHT levels in prostate tissue are significantly higher than in the peripheral bloodstream. By inhibiting 5-alpha reductase within prostate tissue, saw palmetto should theoretically reduce the primary hormonal driver of prostate enlargement. This is the same mechanism exploited by prescription medications including Finasteride, used for BPH, and Dutasteride. Additionally, saw palmetto has proposed anti-inflammatory effects through inhibition of cyclooxygenase and 5-lipoxygenase pathways. The question that clinical trials need to answer is whether these cellular effects translate into meaningful symptomatic benefit in men with actual BPH. And this is where the story becomes complicated. I want to walk you through the trajectory of the clinical evidence carefully, because it is not a simple story, and the nuances matter for your decision-making. The early clinical research on saw palmetto, conducted primarily in Germany, Italy, and France during the 1980s and 1990s, using pharmaceutical-grade standardized lipophilic extracts, was consistently and meaningfully positive. These were controlled trials, many of them randomized and double-blind, measuring validated urinary symptom outcomes and objective urine flow rates. A comprehensive Cochrane systematic review and meta-analysis published in 2000, one of the most prestigious forms of evidence synthesis in medicine, concluded that saw palmetto at 320 milligrams daily of standardized extract produced statistically significant improvements in peak urine flow rate, symptom score, nocturia, and patient-reported quality of life compared to placebo, with effect sizes comparable to those achieved by Finasteride and with a substantially more favorable side effect profile. This was the scientific foundation for saw palmetto's current market position. Now I need you to subscribe to this channel before I continue, because the next part of this review is where the honest medical discussion becomes most important. I'm Dr. James Whitaker, and I produce this kind of careful, balanced medical content every single week. Hit subscribe, hit like, and drop a comment below. Are you currently taking saw palmetto? How long have you been taking it, and have you noticed any difference? Tell me right now in the comments. The story changed significantly with 2 large, rigorous, NIH-funded American clinical trials. The first, the STEP trial, saw palmetto treatment for enlarged prostates, was published in the New England Journal of Medicine in 2006. This was a randomized, double-blind, placebo-controlled trial involving 225 men with moderate symptomatic BPH, followed for 12 months while taking either Saw Palmetto at the standard dose of 320 milligrams daily or identical placebo capsules. Using the American Urological Association Symptom Index, a validated, widely used instrument, as the primary outcome measure, along with objective urine flow measurements, the investigators found absolutely no significant difference between Saw Palmetto and placebo on any measured outcome. The Saw Palmetto group showed no greater improvement in symptoms, flow rate, post-void residual volume, or quality of life than the placebo group. The second trial, the CAMUS trial, Complementary and Alternative Medicine for Urological Symptoms, was published in JAMA in 2011 and specifically addressed the question of whether higher doses might be more effective. Higher doses were not more effective than the standard dose, and neither standard nor high doses were more effective than placebo. These trials represent the highest quality of clinical evidence available: large sample sizes, rigorous randomization and blinding, objective outcome measures, independent funding. Their conclusion is that Saw Palmetto at any studied dose does not produce clinically meaningful improvements in BPH symptoms or objective urinary flow measures compared to placebo in American men with moderate disease. This is why current American Urological Association clinical practice guidelines for the management of benign prostatic hyperplasia do not include Saw Palmetto as a recommended treatment option. So how do I reconcile this with the positive European trials? Several explanations are plausible and have been discussed in the literature. First, the earlier positive trials were smaller and more susceptible to overestimating treatment effects. Smaller trials tend to show larger apparent treatment benefits due to statistical variability, and the placebo response in symptom-based outcomes is particularly substantial. Second, there may be meaningful differences in product quality and standardization between the European pharmaceutical-grade preparations studied in early trials and the dietary supplement products available in the American market. European pharmaceutical products undergo rigorous quality control for fatty acid content, biological activity, and bioavailability. American dietary supplements are not subject to equivalent oversight, and studies have found significant variation in the active component content of commercially available Saw Palmetto products, some containing as little as 20 to 30% of their labeled fatty acid content. A product that does not deliver the active ingredients at studied concentrations cannot be expected to produce studied effects. Third, the patient populations may differ. Men with milder symptoms or different underlying BPH pathology might respond differently than those enrolled in the larger American trials. Does this mean Saw Palmetto definitely provides zero benefit for any man? The scientific answer is, the best available clinical evidence shows no benefit over placebo in average American men with moderate BPH using currently available supplement products. Whether there are specific subpopulations who might respond, men with a particular inflammatory profile, men with very mild early-stage symptoms, men using pharmaceutical-grade European preparations, cannot be definitively excluded by existing trials. What I can tell you about safety is reassuring. Saw Palmetto at standard doses has an excellent safety profile. The most commonly reported adverse effects are mild gastrointestinal discomfort, nausea, stomach upset, that occurs in a small minority of users and typically resolves spontaneously or with food. There are case reports of increased bleeding tendency that is relevant for men on anticoagulant therapy. For men with mild BPH symptoms who prefer to begin with a natural approach before proceeding to prescription medication, Saw Palmetto represents a reasonable, low-risk trial option, with the explicit understanding that the current best evidence suggests it is unlikely to outperform placebo. If you choose to try it, use a product with third-party quality certification. Look for USP Verified, NSF International, or Consumer Lab certification, which provides some assurance of label accuracy. Use 320 milligrams of standardized lipophilic extract daily. Commit to a 6-month trial with systematic symptom tracking using a validated instrument. If there is no measurable improvement at 6 months, discontinue and pursue evidence-based medical options. For men with moderate to severe BPH symptoms causing meaningful quality-of-life impact, I recommend against substituting Saw Palmetto for proven medical therapy. The alpha blocker and 5-alpha reductase inhibitor medication classes have substantially stronger evidence and should be pursued after appropriate urological evaluation. I'm Dr. James Whitaker. That is my honest, evidence-based assessment of Saw Palmetto. Not the answer that maximizes supplement sales, but the answer that best serves your health decisions. Subscribe for weekly evidence-based content. I'll see you in the next video.